Welcome, everyone. Thank you for being here this afternoon. We're going to talk about a broad range of infectious diseases, similar to other presentations. Try to get through them. I'll be available in the back for questions thereafter, and we'll go through cases and such. The main points of emphasis for all the diseases that I talk about today are the importance of timely, appropriate, and adequate empiric antibiotic therapy, and then applying evidence-based wherein there is evidence, or if there is evidence, evidence-based plans for definitive therapy in those that have confirmed infection. So, again, we'll go through a broad range. Of no financial relationships to disclose, I will say that I have pretty significant fervor in managing the affected patient in the ICU, but it's only matched by my emotional disdain and troubles with antibiotic overuse. It's a difficult life to live, as many of you do. Learning objectives are listed here and consistent with the material online as well as print, and it is consistent with our agenda today. I want to break one of my pet peeve rules and abbreviate, or rather use the abbreviation of central line associated bloodstream infection, and I will read the abbreviation of the acronym. And again, one of my pet peeves, but I will be referring these to CLABSI and CAUTI. I will not go so far to say VAP as a word, though. So, ventilator-associated pneumonia, or VAP. It's a hospital-acquired pneumonia subset, technically speaking, arising 48 hours after endotracheal or nasotracheal intubation. The key is the 48-hour mark, implying that before 48 hours, there likely was not a time frame long enough to allow the perceived mechanism for ventilator-associated pneumonia to occur, and that's essentially colonization of the lower respiratory tract, given the influence of the presence of an endotracheal tube stenting open the trachea, as well as a myriad number of other causes. A lot of regulatory attention is being paid to VAP. VAP is considered a ventilator-associated event by the CDC, or a VAE, and it's a subset category as an infection-related ventilator-associated complication, or IVAC. Again, in all of your practices, hopefully you are minding from a regulatory perspective in your interdisciplinary approach to documentation of VAP conversations in regards to it being considered a preventable event. Individual risk factors for VAP are myriad. They involve injury pattern, severity of illness, some baseline illness levels, including underlying chronic lung disease, coma, trauma, burns as well. It accounts for more than 50% of antibiotic use in critically ill patients, and again, it is the most common infection encountered in mechanically ventilated patients. Not critically ill patients as a whole, but in that mechanically ventilated subset. $40,000 per episode, pretty admirable. This is from a 2002 estimation. So if you annualize that and adjust for dollars, it's even more. And we have an estimated attributable mortality, not crude mortality, but attributable, of between 10 and 50%. We know that most episodes of VAP are monomicrobial. However, it can be polymicrobial, and rarely is it from a viral or fungal etiology. The first classification of VAP often discussed is the onset from admission to the hospital or to the ICU, and that's key. It's not necessarily time from intubation. That's the definition of VAP. This is early or late in regards to the time from the introduction of the patient into the more complex environment of the hospital, the healthcare system. So early onset, most often described as 4 days or fewer, and late onset described as 5 days or more. We'll talk more about the IDSA-specific recommendations for risk factors for multi-drug resistant organisms, which again, we'll see this late versus early designation listed therein. The prevalence of bacterial pathogens varies, and I want to make this point key. You all should be students of the ecology of your respective units. And it's not just a one-time thing. It is an annual, maybe even a semi-annual more often, depending on the nature of your patient population, to understand what empiric decisions you're going to make regards to your empiric antibiotic therapies. Protocol-driven approaches have been demonstrated to improve the probability of applying appropriate antibiotic therapy. And again, in our hospital, we have ICUs on different floors, and the flora and fauna of each ICU varies greatly. Probably related to the antibiotic use, probably related to the baseline substrate level of illness of each patient population they're in. But nonetheless, one VAP protocol doesn't fit all, even within one institution. Moving on to the IDSA, multi-drug resistant organism risk factors. These have been challenged, and there are pockets of sustained, proven ability to be a risk factor and signal for risk factor, and some of them have always also been disproven. You can see the third listing is this hospitalization 5 days or more as far as early or late. However, it is important to step back and understand the importance of these as being considerations for broadening empiric therapy, or in the absence of them, maybe curtailing and practicing some stewardship in maybe focused to the onset timing, early versus late. Diagnosis of VAP is difficult. There is no gold standard. The number of editorials disclosing such. Like most infectious diseases, we understand the signs and symptoms, as Dr. Bauer emphasized with pancreatitis. Show me an acute pancreatitis patient who doesn't have the signs and symptoms of infection. They're also the signs and symptoms of severe acute pancreatitis. So too is with VAP. We do have a couple indicators when you get down to the clinical signs and symptoms. Elevated white blood cell count, leukocytosis, fever, and then now getting into maybe more specific descriptors of macroscopically purulent sputum and impaired or worsening oxygenation. Effectively treating and managing, and therefore diagnosing VAP doesn't stop there. We should use culture data to guide our decisions. There are two broad strategies recommended by the guidelines: a clinical strategy or a bacteriologic strategy. Both strategies employ the signals of the signs and symptoms of VAP. However, the clinical strategy will use culture information to make inferences on how antibiotic therapy should be de-escalated. However, the culture is not used as a diagnostic criterion. In contrast, the bacteriologic strategy still uses the presence of the clinical signs and symptoms as an indicator to then execute and perform cultures of the distal respiratory tract, which are described in the chapter. It is then the results of those cultures, hopefully quantitative results of those cultures, that then confirms the initial suspicion as being likely VAP. In other words, if cultures are negative or below growth, there is some evidence to suggest that antibiotics should be considered for discontinuation. So just understand the philosophy in your respective unit on how you all, interdisciplinary-wise, are going to approach the diagnosis of VAP. The clinical strategy has higher sensitivity. If you rely on the nonspecific or the overly sensitive clinical criteria, you will miss NARA VAP, but you will treat people with antibiotics who don't have VAP. If you use the more specific bacteriologic strategy, you may miss. It has lower sensitivity, but the likelihood of overusing antibiotics is lower. Again, it's based on the philosophy. The guidelines endorse both of these strategies. Empiric antibiotic therapy is key. A number of studies have indicated better outcomes, therefore worse outcomes, if we miss. Appropriate antibiotic therapy should be initiated in a timely fashion. You've heard in sepsis within an hour, maybe 4 hours, maybe pie in the sky. But for VAP, the key here is hitting the bullseye if we can. We don't have a crystal ball, so this comes down to, again, educated guesses within the locale of your respective ICUs and the risk factors that your patients may carry. Timing of pneumonia, MDRO risk factors, local pathogen prevalence, and then the antibiogram, antibiotic susceptibility patterns are key. No patient is going to fit. Trying to aim for 100%, although you might be able to in your hospital, likely then is overtreating some subset of population. Again, it all just depends on the philosophy of you and your team. Missed none, missed some. IDSA recommendations essentially organize these considerations into this table. Early onset with no multi-drug-resistant risk factors, we see more community-associated pathogens, similar to community-acquired pneumonia. SANS, atypical organisms. Now, that's controversial. Atypical organisms are most often categorized as atypical as they do not grow easily on our traditional bacterial culture media. So again, interpretation of data at a local level is important. That said, the guidelines do not support overtly covering atypicals up front. Late onset or early onset with the presence of multi-drug-resistant organisms, we now see emergence of Pseudomonas aeruginosa, methicillin-resistant Staph aureus, and additional enteric and non-enteric gram-negative bacilli, Centrophomonas, Acinetobacter, that really wreak havoc in the consideration of hitting the bullseye or applying appropriate empiric antibiotic therapy. We have many challenges. If you go to our neuroscience ICU, 95% of our Pseudomonas is sensitive to cefepime. You go to our medical ICU, 62% of our Pseudomonas is sensitive to cefepime. And cefepime is not unique. You add meropenem, piptazo, you're still right in the 65 plus or minus 2% range. So when we talk about considerations, we, outside of our neuroscience ICU, no doubt are compelled to add a second agent to our beta-lactam foundation. And you can see listed here anti-pseudomonal beta-lactam as the foundation, and then anti-pseudomonal either fluoroquinolone or aminoglycoside. And because of MRSA now, an anti-MRSA agent, linezolid or vancomycin. And there's a number of sessions at Congress discussing the controversies perhaps between linezolid and vancomycin and what to apply empirically for your patient. Definitive antibiotic therapy, so in those confirmed with infection or in whom you decide, along with your team, that they're going to get a specified definitive course of antibiotic therapy. The key here is to balance the duration with the diagnosis. So again, in the clinical strategy, consider discontinuing antibiotic therapy if negative cultures in this clinical improvement. A strategy using the clinical pulmonary infection score, I'm not going to go over here, but it is outlined in the chapter as well as in the IDSA guidelines. So after a brief period, maybe 3 days of empiric therapy, if there is sufficient clinical response in the absence of positive cultures, discontinue antibiotics. Easier said than done, for sure. In the bacteriologic strategy, as I said, if the cultures are negative or below a quantitative threshold that you all have decided is evidence-based and appropriate for your population, consider antimicrobial therapy discontinuation. And search for other sites, because remember what all started this is the signs and symptoms of pneumonia or infection. Definitive antibiotic choices, again, should be based on available evidence demonstrating efficacy and safety. There's a footnote in the chapter regarding doripenem and FDA-related warnings in the management of VAP. So sometimes infectious diseases are treated based on the spectra of the antibiotic. Other times we need to understand the evidence, published or not published, and warnings that we have in front of us, maybe avoiding specific agents. See here some recommendations for definitive therapy, MRSA, vancomycin, or linezolid. Again, good clinical controversy to discuss over time. Pseudomonas aeruginosa, monotherapy, de-escalation after you know the sensitivities and the profile for using a single active agent in immunocompetent patients. It should be considered. If a patient is immunocompromised, continue the concomitant aminoglycoside or fluoroquinolone as per your hospital formulary and available agents. Acinetobacter, carbapenems tend to be the drugs of choice. We know that carbapenem-resistant Acinetobacter is endemic in your area, endemic, epidemic, what have you. Ampicillin sulbactam, the sulbactam component may also be an alternative. We also use colistin at times, depending on the profile of the resistance patterns. Centrophomonas, sulfamethoxazole trimethoprim has been our mainstay. We also know that there's fluoroquinolones and doxycycline, tigecycline, perhaps. Difficult maybe in the antimicrobial testing for some of these agents. Send-outs, maybe e-tests, as Dr. Lamb will go through, but still important considerations in a definitive therapy sense. Extended spectrum beta-lactamase producing organisms, again, carbapenems. We know that there's some evidence that perhaps retained activity with piperacillin tazobactam as well can be considered depending on the flavor of ESBL. Again, a lot of this working with your micro labs, with your molecular diagnostics, getting into really the nuances, and from a pharmacist perspective, sometimes the greatest contribution you can have in these difficult to treat organisms is being creative and understanding the overall phenotypic expression of resistance for these pathogens. So then exercise your PK/PD, exercise your interpretation of what the best therapy should be for this patient. A lot of times, again, being creative and making this up for the first case that you experience, you will come across these if you haven't already. Duration of definitive antibiotic therapy. When I was in training, it was 14 to 21 days from the 1995 IDSA guidelines, from ATIS as well. 2003, the new May trial studied 400 patients, randomized them to 8 versus 15 days, all bronchoscopically diagnosed with a threshold growth of 10 to the 4th or 10,000 CFUs per ml. Really validated, and really the guidelines take wholeheartedly the findings from the new May trial, being if you have a non-Pseudomonas and the patient received adequate or appropriate empiric therapy and has demonstrated a response to said therapy, to then discontinue antibiotics at 7 days. 8 days calendar-wise. If you read the details of the study, it's 7 full 24-hour periods. However, longer durations for those that do not have said response, or if they do have non-lactose fermenting gram-negative bacilli associated with their VAP or causing their VAP. So here, consider 14 days. Key iteration, again, historically being 14 to 21 days, which is a very, very long time in general, pushing the envelope even further with evidence-based suggestions of shorter durations in the presence of response and initial application of appropriate empiric antibiotic therapy. Lack of clinical response beyond day 3 should really beget further workup, consideration of induction of resistance. I will say also a shout out to the new May trial. If you haven't read it, it is in the listings in the chapter. I strongly recommend you do so. Again, it is a bacteriologically guided strategy, so maybe not be applicable to all practices, but it still nonetheless is important. What I like to use on the back last page, essentially, are their clinical response criteria of the traditional things we monitor: temperature, white blood cell, and it's pretty staggering the lack of response in the 2 patient groups over time, but yet patients still receive the randomized 8 versus 15, and you know their outcomes from the study. So again, this whole response at 24 or 48, we probably shouldn't put so much stake on our antimicrobials to be a 24 to 48 hour turnaround of disease. As with many of the infections I'll talk about today, the best way to treat VAP is to prevent it. And we know that the VAP prevalence and incidence is changing somewhat because of the prevention strategies, but also by what I'll call focused coding, pneumonia plus sepsis, rather than coding for VAP, because we know that regulatory-wise, VAP is a non-reimbursable in many pockets DING, if you will, and pay for performance. So first case, CP is a 67-year-old woman with a medical history significant for COPD, type 2 diabetes, coronary artery disease. She's admitted to the ICU with respiratory failure, requiring intubation secondary to severe COPD. CP had a 10-day hospitalization 12 days ago. Day 4 of this admission, worsening infiltrate, left lower lung base with increased sputum production from emission, max temp 38.8, worsening oxygenation despite previous improvement. From initial COPD exacerbation, patient is thought to have clinical VAP and a semi-quantitative tracheoaspirate descent to identify causative pathogens. Which empiric antibiotic regimen is best for this patient? Very good. So answer is B or number 2, given the patient's risk factors, given a previous hospitalization for non-lactose fermenting gram-negative rods, Pseudomonas, as well as MRSA. We can see here that shared spectrum with a beta-lactic foundation is B, and D has the spectrum, but again, aminoglycosides are an additional therapy rather than a foundation therapy empirically. So for central line associated bloodstream infections or CLABSIs, critically ill patients, as we know, often require short-term placement of central venous catheters or lines. More than 40,000 bloodstream infections perhaps related to central lines, and similar to VAP, it is considered a preventable event. Established risk factors include manipulation of the catheter, maybe urgent or emergent placement that may not have been done under the best checklist-guided processes and steps, internal jugular or femoral vein insertion site compared to maybe a subclavian, although all, including even peripherally inserted central catheters, are at risk for catheter eclampsia. Sorry, again, breaking my own rule. Prolonged duration of catheterization in TPN. There are regulatory and clinical definitions for CLABSI. The regulatory minds when you talk about safety indexes, PSIs, but when it comes to the clinical side and the bedside documentation and or decision to treat, the clinical definition reigns. Bacteremia or fungemia in a patient with a central line and the same organism grows from at least one peripheral blood culture or percutaneous blood culture and from the central venous catheter tip, if removed, or if you didn't remove the catheter and you're waiting for cultures to cook, 2 blood cultures, one from the catheter hub and one from a peripheral vein, again, of the same organism. Should have clinical manifestations of infection, fever, chills, rigor, hypotension, and then no apparent source for bloodstream infection other than the catheter. And we know that there can be hematogenous spread from pneumonia, from other sources of infection and types of infections. Diagnosis of CLABSI is similar to this definition that we just went over. General clinical signs and symptoms we know are poorly sensitive and specific. Fever is the most, but again, it's non-specific in a critically ill patient who's at risk for other reasons for systemic inflammatory response syndrome. Paired blood cultures from catheter and from peripheral vein is ideal, again, to get the match, to make sure that it's not just colonization of the catheter. Key point here is a definitive diagnosis requires positive percutaneous blood culture with a positive culture of the same pathogen from the catheter tip or a catheter-drawn blood culture. Easier said than done, too, at the bedside. Patient still has bacteria on a blood culture, so there's a good opportunity for a conversation to figure out what are the risk-benefit of applying antibiotic therapy to these patients. Ideally, blood cultures should be obtained before initiation of antibiotic therapy because of false negative results of your blood cultures. And isolation of Staph aureus, Staph epidermidis, or coag-negative Staphylococci or Candida increases the probability, especially with risk factors, given those are common pathogens and skin flora associated with CLABSI. CLABSI is usually monomicrobial. A lot of it, though, depends on the overall extent of the patient's illness. Common organisms, as I mentioned, gram-positive cocci, Candida species with specific risk factors, TPN being most commonly expressed, prolonged exposure to broad-spectrum antibiotics as well, hematologic malignancy, and solid organ transplant. Enteric gram-negative rods are also key. Similar to the IDSA risk factors for VAP, we use that table and use those criteria when deciding empiric therapy for patients presumed to have CLABSI. Catheter removal is key, source control, if you will. Not a surgical source control, but we'll talk about with intra-abdominal infection, but nonetheless a source control. Inappropriate therapy, similar to VAP, has been associated with worse outcome, increased mortality. So making good, sound, local ecology, patient-specific risk factor-based empiric therapy decisions are key. Empiric antimicrobial therapy should minimally cover methicillin-resistant, methicillin-sensitive Staph aureus and coagulase-negative staph, so vancomycin or daptomycin. There is a warning for linezolid from one study, although it was mainly in gram-negative rod bacteremic patients, it still is carried over in the package insert to avoid linezolid for empiric therapy. Patients at risk for MDROs, again, gram-negative rod coverage, anti-pseudomonal, similar, depending on your local spectrum of activity in your ICU, a beta-lactam foundation plus minus fluoroquinolone or aminoglycoside. And if patients do have risk factors for Candida species, consideration with the new IDSA guidelines for anaconda front line, and again, as you identify the species, you can then maybe de-escalate to fluconazole. Definitive antibiotic therapy, a little bit more complicated when we discuss in the context compared to VAP. De-escalation is still recommended per final culture. Duration is really based on from the first day of positive blood culture, which implies checking serial cultures in the patient. Peripheral is fine, to document microbiologic success. Then from that first day of negative blood culture, count for the definitive duration of therapy. For complicated CLABSIs, remove the catheter. Now we're talking about pathogen-specific, deep-seated infections such as osteomyelitis, endocarditis, immunosuppression for Staph aureus specifically, chronic intravascular hardware that can't be removed, septic thrombophlebitis, and such. Uncomplicated CLABSI, coagulase negative staph, catheter removal, 5 to 7 days. Maybe hard to argue the 5 days. 5 days is Monday through Friday, not Saturday and Sunday. So we lose the circadian rhythm of 1 week or the football number of a touchdown and a point after. Staph aureus, longer, 2 weeks, and uncomplicated. Gram-negative rods, again, 7 to 14 days. And Candida species, similar to Staph aureus, 14 days. Like VAP, CLABSI is considered a preventable infection, preventable event. These are best practices. Some should be standard and some are maybe more advanced. So patient case number 5 for CLABSI. FP is a 29-year-old man admitted to the MICU from another hospital with severe alcohol-induced sterile acute pancreatitis. During his 5-day stay at the outside hospital, he had multiple organ failure, including respiratory failure requiring tracheostomy. A right internal jugular central vein catheter was placed on the patient's admission to the outside hospital. On MICU day 3, so we're talking hospital day 8, FP has a max temp of 38.9. 2 sets of blood cultures are obtained, and the right internal jugular catheter is removed and tipped sent for culture. Which regimen would be best to consider for empiric management of a suspected CLABSI? All right, good. So the preferred answer is D. In the context of vancomycin, cefepime, and tober from a spectrum perspective, is spot on given the risk for multi-drug resistant organisms and having the imperative coverage for MRSA and MRSE. The next most popular answer of daptomycin and ceftriaxone. Downside here is that ceftriaxone does not have anti-pseudomonal properties, and given this patient's risk factors, it would be prudent to consider them in the context of empiric therapy. Linezolid and cefepime. Linezolid, again, carrying at least a precaution in the context of empiric therapy for catheter-related bloodstream infection. But again, if definitive therapy for an MRSA infection, it is a consideration. Moving on to severe influenza. Influenza, as we all know, is a seasonal phenomenon. Those of you that have been in critical care practice for a while know this. In 2009, and the emergence and persistence of 2009 H1N1 is quite interesting in its biology. We know that there's 400,000 or so cases a year of influenza requiring hospitalization. And along with influenza-related illness, which is how FluView and the CDC categorize it. In the 14-15 season, the, if you will, incidence was 65.5 adults per 100,000 population, about 22%, some places higher, some places lower, of hospitalizations required ICU admission. Most common complications are severe. They're quite immediate to the presentation of the patient. Many patients tend to sit it out at home based on previous illnesses and such, but when they come in, they're quite sick. Hypoxemic respiratory failure, bacterial pneumonia superimposed, ARDS, sepsis and septic shock, and rhabdomyolysis. In these patients that have these complications, mortality can be over 50%, and we see a general range in hospitalized patients of 15 to 35%. So quite a perilous disease, basically related to the epidemiology of the influenza viruses involved that season. Clinical signs and symptoms of influenza are nonspecific. We know that. We should probably keep our ears and eyes open when it is seasonal variation. That said, the seasons have fooled us of late in the past few years. We have earlier seasons, we have bimodal seasons, so keep an eye and listen to the local prevalence and patterns in your areas. Laboratory diagnosis is needed to confirm, and this is key when deciding definitive therapy. Viral culture, serology, rapid diagnostic testing, and PCR are options. Some of the rapid tests should be used up front, and these can be used in available upper airway material, nasal swabs and such, nasal washings. They are very specific, so a very low false positive rate, but they're not very sensitive. So if the clinical suspicion is there and a negative test, it is recommended to move on to more confirmatory tests such as reverse transcriptase PCR. Management of severe influenza, stabilization of the patient, supportive care, treating the primary influenza, any secondary bacterial infections, as well as non-infectious complications such as ARDS. Empiric antiviral therapy should be initiated specific to the patterns of the seasonal outbreak. One thing that has been very consistent over the past 4 to 5 years is the lack of utility of amantadines and the superiority and supremacy of the neuraminidase inhibitors. Hospitalized patients receiving antiviral therapy after 48 hours has demonstrated some benefit. So the rule, maybe in the outpatient world of, oh, you're outside your window of potential benefit. In the ICU, the risk-benefit is to apply the therapies. Again, neuraminidase inhibitors have emerged as the mainstay for influenza A and B strains of most contemporary seasonal outbreaks. This is a list of the therapies. There is an error in the chapter for amantadine. The dose was omitted at 100 milligrams twice a day, so please note that. We know that Peramivir is now available in an IV formulation, however, not indicated in critically ill patients, and the number of patients in the published literature that were critically ill managed with this agent in its compassionate use program, as well as in a case series from 13, suggests that there may be utility, but it's a little bit guarded. Anytime in a critically ill patient with quite deranged physiologic parameters, including PK/PD assessment, one-time dose of a drug that you would have given to a patient on the floor who might be otherwise not critically ill should mainly raise a red flag until maybe confirmed later. We see also Temavir, for that matter, maybe being the prominent therapy, and there are recommendations and reasonable reports of using 150 milligrams twice a day compared to the 75 milligrams dose. So case number 7 for influenza. TY is a 32-year-old woman who has had flu-like symptoms for the past 72 hours, presents to the ED from home with severe fatigue, shortness of breath, and rigors. TY has a heart rate of 120 beats per minute, menotorial pressure of 70. Respiratory rate of 24, temperature of 39.3, and arterial oxygen saturation of 85% of room air. Because in the middle of influenza season, where in the local area there's a high prevalence of influenza A and B, a nasal swab is done and sent for rapid diagnostic testing for suspected influenza. Shortly thereafter, TY is intubated for severe respiratory failure and admitted to the MICU. In addition to empiric antibiotic therapy for community-acquired pneumonia, which would be the best considered next step. So none, the patient is outside the time window, await rapid diagnostic testing, give amantadine, or give also Temavir. Good deal. In general, for empiric therapy, given the severity of illness here, giving also Temavir is probably reasonable. If it was rapid diagnostic testing, depending on your local lab and their response, it's just, again, risk-benefit whether you do wait, which is answer B, or, again, initiate the therapy. Given the severity of illness, I would attend in our institution to administer therapy, initiate also Temavir, or neuraminidase inhibitor. The inhaled therapies are not recommended given their limited bioavailability, potentially in a mechanically ventilated patient. So the GI route of also Temavir, and there's some controversies discussed in the chapter, are probably reasonable at this point. So for catheter-associated urinary tract infection, or CAUTI, urinary catheters are common, hopefully becoming less common. Just one example of best practices, at our hospital we do a daily safety brief for the whole hospital every morning, and we report every morning how many patients have urinary tract catheters as a potential opportunity to improve awareness. I recommend that in your interdisciplinary administrative groups in your ICUs that you guys work towards strategies to increase the awareness of these catheters being present so as to maybe decrease their overall use and overuse. CAUTI is the most common infection in critically ill patients. Again, VAP in mechanically ventilated critically ill patients, but all critically ill patients, it turns out to be CAUTI. CAUTI indice, Incidences and prevalence are changing as well, maybe because of strategized reporting or strategized coding, but it's still important to understand that these infections can occur with prolonged catheterization. Similar to VAP, similar to CLABSI, there are CDC and IDSA surveillance definitions. From a clinical perspective, clinical signs and symptoms can help differentiate CAUTI from catheter-associated asymptomatic bacteria, which likely does not require antimicrobial therapy. However, they're nonspecific for CAUTI versus other infections, maybe more specific if you assess flank pain and other symptoms from patients, but that's very difficult in the ICU, as we know. Urine culture should be obtained, urinalysis should be obtained, and here may be some hints. Pyuria, or presence of white blood cells on urinalysis, without signs and symptoms does not indicate CAUTI, whereas the absence of pyuria in a symptomatic patient suggests a diagnosis other than CAUTI. So, again, important to maybe devise a therapeutic and diagnostic strategy. In Dr. Lamb's chapter, there is a nice algorithm in that regard recommended from the CDC from a regulatory definition perspective. Etiology of CAUTI, unlike community-acquired, where E. coli may reign 70 to 80% of the time, it's not that high, but E. coli is in fact still number one. It's only about 30% of the time, so there's another 70% of organisms in the cornucopia of potential pathogens. Additional bacterial pathogens that are and should be considered are gram-negative rod, specifically non-lactose fermenting agents, or organisms rather, including Pseudomonas ruginosa, gram-positive cocci, and Candida, which can be involved up to 1/3 of cases. Management, again, baseline principle, if possible, to send cultures before initiation of therapy. If the catheter has been in place longer than 2 weeks, it should be removed and replaced. In our practice, we remove them when there is suspicion of infection pretty often. Systemic empiric antimicrobial therapy based, again, similar principles as VAP on local pathogen prevalence, local antibiograms and such. Empiric therapy should be de-escalated once a pathogen is identified and the diagnosis of CAUTI is made, confirmed. Empiric therapy should be discontinued in patients without CAUTI diagnosis. Bladder washings seems to be still a present novelty. There are some nice editorials and recommendations perhaps against, and if you, from the perspective of the true cystitis or tissue infection with the bladder maybe not being absorptive surface, bladder washings likely have limited utility. Shorter durations of definitive therapy should be considered based on response, perhaps. If they respond within 72 hours, maybe 7-day duration of therapy. If the response is delayed beyond 72 and CAUTI is the withstanding infection present, then perhaps up to 14 days. Patients with persistent signs and symptoms should have a urologic workup, perhaps for urinary abscess and renal abscess. Similar to VAP and CLABSI, CAUTI is considered a preventable event, again, in an interdisciplinary way, coming up and devising strategies to minimize the use of catheters and definitely limit the duration of the indwelling catheter. Complicated intra-abdominal infection. Moving right along. So complicated intra-abdominal infection is an infection that extends beyond the hollow viscus of origin into the peritoneal or retroperitoneal space. These are very difficult infections to manage. It is a co-management, if you will, from an interventional perspective, be it surgery or interventional radiology, along with medical management with antimicrobial therapy, resuscitation, management of sepsis and septic shock, depending on the patient's presentation. Incidence varies given the breadth of illness, all the way from appendicitis to acute perforation of large bowel, small bowel. Accounts for up to 21% of sepsis and 30% of septic shock cases. So again, most often the disease severity is high, and it is the second most common cause of mortality in critically ill patients. You can see here crude mortality rates between 30 and 50%, so it's quite a perilous disease. Peritonitis in general is divided. There's some very nice review papers outlined in the chapter, surgery focused in many cases as well. But primary peritonitis, secondary peritonitis, and tertiary peritonitis. Primary peritonitis, as discussed by Dr. Bauer, is essentially spontaneous bacterial peritonitis. So peritonitis that really had no disruption of a viscus, no disruption of any anatomical barrier of the GI tract, but rather related to translocation is one idea from the GI tract, bacteria that then translocate into an available space or the acidic fluid. Secondary peritonitis is more of the complicated intra-abdominal infection where we do have likely from macro or micro perforation of a hollow viscus, be it gastric, maybe even esophageal rupture or perforation to then small bowel and large bowel. Causes include direct trauma, ischemia, thrombosis, which then lead to tissue ischemia downstream, ulceration, malignancy, and an anastomotic leak in someone who has had a primary operation requiring resection. Tertiary peritonitis is a complication essentially of secondary peritonitis. Peritonitis that persists or recurs after 48 hours of managing primary or secondary peritonitis. As you would guess, the mortality rate for tertiary peritonitis is even higher than primary and secondary, given it's a complication of those previous types. Clinical signs and symptoms and radiographic assessment are the cornerstones and foundation of assessment and differentiation from other infections. Pathogens influenced by the type and cause of peritonitis. Similar to other infections we've discussed, the presence or absence of MDRO risk factors, previous antibiotic exposure, and patient-specific colonization. Very hard to determine. In VAP, in some ICUs, there is ongoing surveillance, perhaps, of endotracheal aspirates. It's very hard in these patients, given they often present in the acute extremis of their disease, to know what their flora and fauna are. So again, it reverts back to broad empiric guesses and assessment of the presence of these IDSA, MDRO risk factors. Primary peritonitis is usually monomicrobial. Again, maybe translocation, so we even see perhaps pulmonary translocation of strep pneumo into the acidic fluid, and then enteric translocation, E. coli, Klebsiella, maybe even Enterococci. Secondary peritonitis, usually polymicrobial. There's not one organism that is allowed to leave the perforated area. It's essentially all of the available organisms in the milieu. So a lot of this now depends on guessing what are normal gastric and esophageal or duodenal flora, what are normal middle or small bowel, proximal or distal flora, what are large bowel flora. Again, it's a guessing game in the empiric sense. Perhaps when we get to the management, we can get infected material cultures to help guide us, but empirically, it's really based on the anatomic insight that we have for the locale of the injury, maybe from the radiographic assessment, but most often from the surgeon and or interventionalist to tell us what in fact was involved. So resuscitation, very specific to surviving sepsis campaign. Primary source control is key. Again, similar to VAP and maybe not having too high expectations for antibiotics. Without source control in intra-abdominal infection, there should be zero expectation for your antibiotics. Without affecting and dealing with primary source control, it's essentially bathing abscess physiology with antibiotics, which inoculum effect, again, very difficult penetration, given that these are not blood perfused areas. They're outside, if you will, in the peritoneal cavity. Empiric antimicrobial therapy should, again, be based on broad empiric guesses and hunches, MDRO risk factors, the location of said injury or perforation, the extent of illness, as we'll see severity-wise. So if we have community-acquired intra-abdominal infection with mild to moderate severity, we can see here spectra to cover enterograminative rods, maybe, if we're talking about lower GI tract, anaerobes, ertapenem as a carbapenem here, narrow spectrum, anti-enterococcal and anti-pseudomonal therapies generally are not necessary. Even if it is distal bowel for enterococci, if it's mild to moderate disease severity, anti-enterococcal therapy is not recommended. Now moving to community-acquired, high severity defined as shock, advanced age, immunocompromised, or a delay, or high likelihood of delay or failure in achieving source control. Now it's very similar to having MDRSO risk factors, where you talk about anti-pseudomonal coverage, anaerobic coverage, anti-enterococcal, maybe even gram-positive cocci, as you determine the flora, as you determine perhaps the risk factors in the patient. Broad-spectrum carbapenems, cefepime or ceftaz plus metronidazole for the anti-anaerobic therapy, ciprofloxacin or levofloxacin plus metronidazole, and then piperacillin and tazobactam. Please note the asterisks listed for the cephalosporin metronidazole regimen and the fluoroquinolone metronidazole regimen. It is recommended that you may have to add secondary anti-enterococcal therapy in this community-acquired high-risk group. Healthcare associated, now we broaden, very similar to VAP, and we add to that previous list of high severity MRSA, anti-enterococcal therapy, anaerobic therapy. Antifungal therapy should be added to the regimen of patients with yeast on gram stain or recent evidence of yeast colonization. And the way we use this in practice, you have a patient that just is yeasty, we kind of say at the bedside, a little bit flippant, but they've got a little yeast in their urine culture. It wasn't enough to call it a caudy, but they had some yeast there. Again, they've had prolonged antibiotic exposure. Maybe now we start talking about if they do have peritonitis or a perforation of hollow viscus, empirically adding, based on the severity of their disease, antifungal therapy. Definitive therapy, controversial, especially when we talk about complicated intra-abdominal infection. There's some good evidence of late for uncomplicated appendicitis and antimicrobial therapy in the context of surgery or no surgery. But for complicated infections, peritonitis, secondary or tertiary, trying to limit it if we can, 4 to 7 days. A lot of it depends on the success of source control. Tertiary peritonitis is already a failure of said source control and therapy, so maybe longer duration. Response to therapy should be evaluated daily with clinical signs and symptoms. Persistent signs, here again is a good opportunity for interdisciplinary conversation to discern the success. Most surgeons believe that success is had, or else they would not have stopped the operation. So sometimes it's a difficult conversation, but it's one nonetheless to have. Is source control achieved? And if not, then again, having high hopes with antimicrobial therapy is probably misguided. So we have to look and discern with radiographic assessment, again, surgical evaluation, interventional evaluation of that source control. So a complicated intra-abdominal infection case. DL is a 69-year-old woman admitted from home to the SICU with severe acute abdominal pain, left lower quadrant. Abdominal CT reveals free air in the peritoneal cavity and evidence of distal ischemic colitis. DL is taken urgently to the operating room where she is noted to have gross contamination from distal colonic perf and marked peritonitis. After a partial colectomy and abdominal washout, she is admitted to the surgical ICU for continued resuscitation for septic shock. Which empiric antibiotic regimen would be most appropriate for DL? Well, at least it wasn't cefepime, vancomycin, and Tobra this time. So probably the best answer is piperacillin, tazobactam. Option number 2 here, given that it was colon and the severity of disease, having specific anti-enterococcal therapy is probably considered, and that's where the piperacillin comes in. Ciprofloxacin, is kind of a plus-minus agent. I don't know what reference you all may use clinically, but plus-minus maybe in urine for enterococcus. But given the severity of illness here, I would go with the piperacillin tazobactam. Ertapenem as coming in number 3 answer. Reasonable from the anterior gram-negative rod, from the anaerobic perspective, but perhaps with the septic shock, with the complexity of disease, having an anti-pseudomonal agent is probably recommended at this point. Severe acute pancreatitis from an infectious disease perspective, to complement Dr. Bauer's presentation. About 20% of acute pancreatitis episodes are severe with evidence of necrosis. Pancreatic necrosis is most often sterile. However, most often leaves us uncomfortable many times. About 1/3 of patients with necrotizing pancreatitis will have infected necrosis. Again, similar to intra-abdominal infection, defining the presence of infected necrosis without doing intervention is often difficult. Pancreatitis-associated systemic infects are complicated. They mimic other diseases associated with SIRS. In fact, some of the strongest SIRS patients, if you will, that I've managed, in fact, were severe acute pancreatitis. Hypovolemic shock, hypoxemia, perhaps from ARDS. Again, some of the worst ARDS that I've seen was associated with acute pancreatitis, and some of the epidemiology supports that. Acute kidney injury, GI bleeding, a myriad effects of critical illness and multi-system failure from a single organ being affected. Mortality for necrotizing and infected necrotic pancreatitis is as high as 40 to 60%. Pathophysiology, generally it's a result of glandular autodigestion, if you will, from excessive ductal and tissue production and exposure, amylase, lipase, protease. Trypsin-related indications from macro or macro blockage of the duct, overexpression of these enzymes as well. Not necessarily controversy, but a number of theories and a number of causes to boot. Diagnosis requires really two of the following three features: acute and constant epigastric and right upper quadrant abdominal pain, with or without nausea and vomiting, serum amylase and or lipase greater than 3 times upper limit normal, and characteristics of acute pancreatitis on CT scan is the firmest of the diagnostic criteria. Pancreatic necrosis or abscess is evidence on that CT scan. Acute pain management, fluid resuscitation, supportive care, nutrition support. Empiric antimicrobial therapy indicated in patients with suspected or confirmed infected necrosis or pancreatic abscess. So whether it's radiologic or radiographically guided drainage, so percutaneous drainage, or if there's an aggressive acute care surgery service, perhaps doing operation. I had always learned as a pharmacist in the ICU, especially in the surgical ICU, that rule number 5 of surgery is don't mess with the pancreas. So maybe you don't go operate on the pancreas. Antibiotics of choice include broad-spectrum carbapenems, fluoroquinolone plus metronidazole or third-generation cephalosporin, plus metronidazole, perhaps in the context of their enhanced pancreatic penetration compared to other agents. Antifungal therapy, additive yeast is identified on culture is key. So similar to intra-abdominal infection, using empiric therapy in the absence of culture will just lead to prolonged empiric antibiotic therapy versus the opportunity to de-escalate to a definitive focused therapy specific to what was found in the infected material. Empiric agents to be discontinued if cultures are negative. Again, easier said than done. Go back to the clinical diagnostic strategy of VAP. The patient still looks ill, they're likely to be continued as an interdisciplinary conversation on your service. Definitive therapy may be continued up to 14 days. Again, these patients are quite ill. The quiescence of disease likely prolonged compared to maybe other removable causes. And a lot of it is compounded by the fact of the sterile aspects of pancreatitis now superimposed with the infected aspects of pancreatitis. Controversial, and Dr. Bauer touched on, is prophylactic antibiotic therapy. Not recommended. Again, though, very difficult in the clinical presentation of these patients to not call the antibiotic therapy you're applying empiric until we then figure out radiographically if there is or is not infected necrosis. So very difficult, good conversation to have. Evidence supports, however, if it is a prophylactic aim to applying antibiotic therapy, that is not supported. So acute pancreatitis case, check on time, sorry. TJ, a 27-year-old man admitted to the MICU from an outside hospital with alcohol-induced acute pancreatitis and associated respiratory failure, systemic inflammatory response syndrome, and blood pressure of 155. Abdominal CP shows severe pancreatitis with about a 30% necrotic area and large focal fluid collection requiring guided drainage. A fluid sample is sent for gram stain, which reveals many gram-negative rods and yeast. Which antimicrobial regimen would best be initiated in TJ? Good. So the answer, imipenem fluconazole is preferred, given the spectrum, the severity of illness, the pancreatic penetration of imipenem is recommended, and then the addition of fluconazole, given the presence of yeast on that initial gram stain. Again, definitive culture can be de-escalated from empiric regimen here as the final culture results unveil themselves and manifest. So fungal infection here is Clostridium difficile infection. We all likely have experience in managing C. diff. It's a critically ill patient where it gets a bit more complicated. Most often as they present to the ICU because of their C. diff, rather than develop C. diff as a consequence of their critical illness and or antimicrobial use therein. Incidence ranges 3 to 10 per 10,000 patient days. Again, C. diff seen as an indicator of patient safety from a healthcare quality perspective. Clinical manifestation ranges from symptomless carriage to fulminant and sometimes fatal pseudomembranous colitis, toxic megacolon, and colonic perforation. Systemic complications, like any other infection, systemic inflammatory response, all the way to multiple organ failure. We know that crude mortality in severe C. diff infection may be as high as 75%. C. diff is defined as the presence of symptoms, diarrhea, although I will say if somebody has significant right-sided disease, perhaps formed stool will be present. So heck with that as a must-have diagnostic criteria, so quite difficult in that context. A stool test positive for C. diff toxin or toxigenic C. difficile or pseudomembranous colitis on colonoscope. Severe C. diff infections consistent with IDSA guidelines, defined as an elevated white blood cell count above 15,000 cells or serum creatinine 1.5 times greater than premorbid level. Emanates from one study. There are some suggestions that this may carry some water. I think there's some unanswered questions here. Nonetheless, they're probably good empiric indicators of a sicker patient. Severe complicated C. diff infection, which is really the meat of the recommendations of understanding for this critical care focused management of the C. diff patient. Hypotension, shock, colonic ileus, and toxic megacolon, which really provide opportunities to be creative and really necessary in your creativity to try to find a way to apply topical therapy to the patient's GI tract to essentially eradicate the C. diff organisms. Removal of potential causes, i.e. antimicrobial therapy, antibiotic therapy. Assessment of disease severity is key in helping then discern the risk-benefit of the therapy. Evaluation of the need for surgical intervention, all the way from subtotal colectomy with rectal preservation. In fact, our acute care surgery service of late has tried to do colonic sparing operations, diversion, if you will, creating an ileostomy, and then an opportunity to then irrigate the colon with vancomycin per se to see how it goes and maybe then reattach the colon to the ileus or the ileum. So pretty cool stuff. Again, trying to preserve rather than do a subtotal colectomy. Samples for diagnostic testing should be obtained before empiric therapy. Not as imperative, especially because we're not talking about a culture. In most cases, maybe a toxin or DNA amplification test. And again, antibiotic therapy targeted against C. diff as empiric management in patients with suspected disease. This should look familiar from the IDSA guidelines. I will draw your attention to the initial episode, severe complicated C. diff infection. If you're a student of evidence-based medicine and what has been reported for really the most difficult patient, which is the patient who has an ileus, maybe in whom IV flagyl or IV metronidazole and vancomycin administered orally or by OGNG may not have enough confidence, especially with the vancomycin in a patient who has an ileus. And because remember, you're trying to deliver to the distal colon, where in fact the C. diff are, to eradicate the infection. So we oftentimes find ourselves having good conversations about using vancomycin enema. Again, if a patient is post-operative, we had a patient last week who they suspected rectal C. diff, not common, but the patient already had a colectomy, and the patient had persistent signs and symptoms, and they sent a rectal swab, and in fact was positive for C. diff, so we wanted to treat the rectal stump. So the patient, that rectal stump is in discontinuity of the rest of their GI tract, so you have to be creative and apply vancomycin enemas. Even without that, if a patient does have their colon in situ, now the conversation becomes IV metronidazole plus vancomycin enterally. Does the proximal delivery of vancomycin, how much confidence do we have versus now a rectal delivery? Our guidelines recommend 100 mLs. I will say have a conversation with your physician group, have a conversation with the surgeons if they're involved to figure out where perhaps the disease is. 100 mLs likely will not get past that rectal stump. So if a patient has maybe transverse colon disease, best you know, or the sigmoid, or even right-sided, you may have to have a difficult conversation about the volume of enema. We also use rectal collection systems because the enemas ideally should be retained. It's very difficult for a conscious patient to retain an enema for an hour, much less an unconscious patient. So think about it beyond maybe the guideline recommendation of 100 mLs. 100 mLs may be safest, but you got to have a risk-benefit assessment of trying to now cover, if you will, literally the topical therapy of vancomycin. So, patient case 10. KL is a 57-year-old man admitted to the MICU with diffuse abdominal pain, fever of 38.8, white blood cell count of 27,000, heart rate of 125, mean pressure of 57. Abdominal CT scan reveals a large amount of intestinal air, suggestive of ileus, and moderate transverse and sigmoid colonic inflammation. On review of the patient's history, KL was recently completed a 4-week course of broad-spectrum antibiotic therapy for a post-operative osteomyelitis after repair of a comminuted femur fracture, increasing the suggestion of C. diff infection. Which regimen would be best as empiric management for CD's expected C. diff? All right, so very good. Picking up on some of the cues in the case of ileus, the severity of disease, obviously. So metronidazole IV plus now intracolonic vancomycin. Again, the conversation could be, well, let's try enteral vancomycin. Let's try OG-NG or oral to see what we can get in response. But in general, with that degree of ileus, as well as the location of the infection and severity, it likely would behoove the consideration for intracolonic vancomycin. Flagyl orally, again, is going to be complicated perhaps by the ileus. Metronidazole alone, not recommended for this level of severity of disease. Sorry for going quite quickly. I thank everyone for your patience, and I will be in the back if there's any questions. Thank you.